Typically, a Kaizen event is a short duration, a short period of time where you do rapid improvements. It's analogous to if you were going to eat the elephant, maybe take the whole leg in 4 days, and then you're left with action items at the end of the event. So it's very episode, or we say episodic type of improvement events. Kata is a routine for practicing and becoming a part of your daily continuous improvement culture. It's taking small steps, so maybe just a small bite of the elephant. The 5 questions keep you focused and targeted on how do you want this process to operate in the next week or 2 weeks out, and what obstacles are keeping you from operating in that target condition. We step back and look at the current situation and then develop experiments or PDCA cycles to try and go around those obstacles to get one step closer to that target condition. Every day a step closer, and all of this is in line with the vision and the challenge for the company. All right, good morning. I am pleased to have Karen Clark, point of care supervisor at Baptist Memorial Healthcare in Memphis, Tennessee. Karen's worked for Baptist Memorial for 40 years. She's also an ambassador to many of the Baptist Memorial locations. She's certified JI and JR trainer. Next, we have Kristen Quinn. She's the CVICU manager at Baptist Memorial Memphis. She's also been a Kata practitioner for several years and a very creative nurse. I've coached Kristen in many Kata training sessions. We have Sarah Governor, head nurse and lead ECMO coordinator from the transplant unit there at Baptist Memorial Memphis, and also Jennifer Graham. She's the transplant manager and works a lot with the ICU units there at Baptist Memphis. So welcome, ladies.
Good morning.
Good morning. So first I wanted to talk about some of the things I've been reading in the Daily Memphian, and they make posts on LinkedIn from time to time. And there's some really interesting things that's been happening ever since COVID-19 started coming into the news, and the Daily Memphian has covered a couple of very interesting articles about some of the work you've done in CVICU and things you've done to help your patients and help your patients get over it in your treatments with COVID, and how you fought back against the virus in some very creative ways. And so we're going to dig into some of those actions this morning. So my first question is, could you tell our audience what it was like the very first beginning days when you were hearing about the hot spots in New York and New Orleans, and you were starting to get prepared? And Karen, you and I talked a little bit about that, and there was some executive meetings, some top level meetings that were starting to get together, but you hadn't seen any patients yet, but you were hearing some things. And I think, Sarah, you had mentioned you'd heard some things like 25 intubations in a 24-hour period. So what was it like during those first days when you guys were hearing about the disease?
So in the first couple of days, or the first couple of months of the year, when there was rumors of things going on and what is it and what to do, I know the CDC and the government really stressed that we needed to flatten the curve. The curve they were afraid was really going to be very steep in March and April. So we were looking at ways that we could be prepared for that. Looking at our supplies of PPE. To be able to test for COVID, and just to be able to take care of, some of the very sick patients that we would see. Here at Memphis, we are one of the only adult ECMO programs in this region, so we knew we would be getting the sickest of the sick of these COVID patients. And I know Sarah can talk to, the things from nursing, what they were seeing as far as patients being put on the ventilator. So I'll let Sarah speak to that.
Okay.
I feel like, sorry.
Go ahead.
We started seeing patients on the ventilators in mid-March, if I remember correctly, early to mid-March with COVID. And I think in general, it didn't feel to me at the time any different than any other a flu or anything else. With how it looked in the patients, it felt different on a personal level because it's scary, you know, when you're bedside and you don't know what it is, and you don't know how to protect yourself and how to protect your family, and then you hear stories in New York and New Orleans about people sending their kids to live with grandparents to protect them, or people staying overnights at the hospital just to continue work, you know. So from a bedside standpoint and a nursing standpoint, there's a lot of anxiety and a lot of fear coming into it, and you just never knew, you know, when you heard stories, when we heard that they intubated 25 people overnight in New Orleans, I think, and it just happened all of a sudden, you know, there was no pre thing, it just happened. And I think those kind of things really, in general, on a personal level, scared a lot of people. Thankfully, that fear drove us to a lot of action. And at the heart of healthcare, I think a lot of people in healthcare are planners, and we are planners with OCD. And I feel like that helps us. And so we utilized as much as we could. We directed our fear and our anxiety towards planning for the worst and hoping for the best. So when we started putting people on ventilators and hearing that they were getting worse really quickly, you know, within an hour, within minutes, within overnight, you know, people just getting worse so fast, I think we sort of felt a sense of calmness knowing that we had plans in place and we had administration on our side. We were all sort of came together as one big team, and administration was so supportive with any supplies we needed and personnel things that we needed. You know, it just felt, if we needed something, we could get it. And I feel like that in general helped calm a lot of people's anxiety. We never had fears about, like Karen said, about our PPE. We never were scared that our patients weren't going to get what they needed, or that we weren't going to get what we needed at the front line.
Yeah, I can say from experience from coaching both ICU nurses and ED nurses, after about the first 3 to 4 months, I could pick out which nurses out of a crowd were ED nurses and ICU nurses versus the rest of the floor nurses. And it seemed like the ED nurses talked really fast, wanted very short communication, but they wanted very accurate information. ICU was more calm, they wanted even more data, they wanted to be more exact, but the handwriting was just absolutely perfect on some of the boards, and they're very detailed and wanted to know why they were putting information in certain places and stuff. So I can imagine some of those things, but I can feel for you, for your families, and some of those scary things you're talking about there. Speaking to the Baptist management systems and some of the trainings that you'd had for several years going into this, was there any existing trainings that you had that you fell back on, or that you just reacted to, that helped out early on, that you felt helped you get a good start on this?
Well, Brandon, I think it's really interesting that with our TWI, training within industry, you know, 3 or 4 years ago when we really started with TWI, one of the things that we did, one of the first job instruction breakdowns that we started with was hand washing. So that has really served us well, you know, to know that through our entire hospital, everybody is trained on the proper way to wash their hands. So when all of this came about, we have it when we have new employees as part of their onboarding. And now, since this has come about, you know, administration has put out a lot of reminders on, you know, wash your hands, wash them for at least 20 seconds. So I think that was very just wonderful that one of the first jibs that we actually taught has really helped us in this pandemic.
Yeah, it's very practical, especially I remember Patrick Gropp put out a LinkedIn video of teaching his daughter how to do hand washing and using that jib, and it was very, very accurate, very, very straight to the point, very easy to follow. I taught my sons how to wash their hands, and after they couldn't sit through the 7 times, about the 3rd time, my 16-year-old was, "I've got it, Dad, I've got it," you know, and he said, "I can do it. I guarantee you I can do it." and I had to make him slow down and go through it I think I frustrated him before it was over with, but he just kept going thumbs, thumbs. You know, he kept get to that point. But you know, all of us in the public, we kept hearing the president and kept hearing Governor Cuomo talk about ventilators, ventilators, ventilators. We need more ventilators, and then we were hearing statistics like only 80% of patients that go on a ventilator or get intubated actually come off the ventilator. What was some of the things that you found that you needed to do, or were you prepared, or how did the intubations go with some of the sickest patients you mentioned, Karen, that you first had, and what are some of the things that this group had to overcome?
Well, Brandon, I'm really going to have to pass that one to either Sarah or Kristen because they are truly the experts with dealing with ventilators. So if you don't mind, I'm going to let them speak to that.
Absolutely, absolutely.
So when we had a patient that needed to be intubated, we quickly discovered that we heard and we discovered through the news and everywhere else that a lot of this is spread through aerosolization. So we wanted to make sure that our staff was protected. On top of their standard PPE that they wore for COVID patients, we also, a physician nurse's husband made some plastic boxes that we use now for intubation. They put that over the patient's head. It doesn't go on their body or anything. It just kind of protects the area. And when the doctor intubates the patient, there's holes that they can put their hands through the box to intubate. But it helps protect all that aerosolized air from going into their face and into the nurse's face when they're in the room. So that's one of the things that we have used a lot in our practice. I think the doctors really like that. We've come up with interesting things. Our respiratory department, had a great count on how many ventilators we had, how many patients were on the ventilator. But then we also knew, and Dr. John Craig, who's one of our CD surgeons, knew that there could be a need for ECMO in the ICU, and so that is something that we prepared for really quickly, and the rest of our leadership team at Baptist Memphis prepared for. So typically in our CVICU, we only have 2 standardized negative pressure rooms, which a COVID-19 patient needs a negative pressurized air room. So quickly, they converted 16 of my beds in CVICU to negative pressure rooms. So that was very helpful. So if we got a COVID patient, or even a pending COVID patient, we were easily protected by putting them in the negative pressure room.
So for our audience, negative pressure means when you open the door, the air comes in, the air doesn't go out, so the contaminants don't go out of the room and
Correct.
contaminate the rest of the unit there. Okay, keep going.
Dr. Craig wanted those rooms in CVICU to be negative pressurized pretty quickly because he knew that there could be a possible need for the ECMO patients to come to our unit.
And ECMO stands for, I'm sorry, just for our listeners that aren't medical background, ECMO is?
I'm going to let Sarah talk about ECMO because she is the expert on ECMO.
Okay.
ECMO stands for extracorporeal membrane oxygenation.
Okay.
All that means, extracorporeal, sort of like extraterrestrial, it's out of body. So it's out of body oxygenation on a membrane is all it is.
Okay. And the function there, Kristen, that you were using, you only had 2 units, or you were starting to use?
Yeah, we have 30 beds in our CVICU. Only 2 of those were made with the building to be negative pressurized. Well, Dr. Craig knew quickly that if we needed to have multiple ECMOs, there wasn't going to be enough room, a negative pressurized room for that. So he spoke with transplant and with me and our administration, and what we kind of all decided was that a COVID positive patient could never go into the transplant ICU unit, which is where they typically do all of the ECMO patients. So if it was a COVID positive patient that needed ECMO, they would have to come into CVICU, into that unit. So that's why he needed the negative pressurized rooms, and they moved really quickly on those. And then Sarah and her team helped train some of our team. So I'll let her talk about that and how, we were able to train other people on the ECMO procedures and how to do that one.
When we talked about doing the ECMO, we have different ICUs in the hospital, and there's ICU downstairs, Concourse ICU. There's 4 ICUs down there. And then, of course, upstairs with us in CV, there's 4 ICUs. And transplant, we're number 4. When we talked about where could we do more ECMO, it was about the best thing for the patients and the best things for the nurses that would be running those ECMOs. And so when we do put people on ECMO, 9 times out of 10, we do it at the bedside. And so that requires a lot of people and a lot of equipment. And so that immediately ruled out the downstairs ICUs. So we could not use those rooms. They're too small for all the equipment required to turn each little ICU room into an OR suite, essentially. And so we immediately began to look at CV and talking to Kristen about utilizing some of her rooms for our ECMO patients. The other reason we wanted it up in CV is because our transplant nurses, some of them are trained to run the actual machines, and their job was to run these ECMO pumps. And we still have ECMOs that are non-COVID related in our transplant ICU units. And so in order to keep our resources tight and our people together, if you need help, we didn't want to send nurses downstairs, and if they needed something, then I would have to run all the way downstairs to help, or Jennifer would need to run downstairs. It's just right next door. So it was sort of the best option was to do CV when we picked those rooms. We train our transplant nurses, have all been trained just as part of coming into the unit to be the bedside caregiver for an ECMO patient. What that means is they're trained in the big picture of ECMO, what it is, how it works, how does it work when you give fluids or you take fluids away, when you give blood or you take blood away, how does it work in the big picture of things, so that you can talk in an educated manner to the family, keep them informed about their loved one's status, and also so that you can help manage the patient overall. When we talked about putting ECMO patients in CV, we knew immediately that we would need to train CV nurses to be that bedside caregiver component. That's a 4-hour class, and in conversations with Jennifer and with Kristen, we were able to really quickly train almost 30 of their staff members, because again, we were preparing for the worst and still are prepared for the worst and just hoping for the best in this, that we could support upwards to 15 ECMOs at a time if we needed to. And so that was sort of our thought. And so Kristen was able to move her staffing around, and Jennifer was able to move our staffing around and move my schedule around, and we were able to get all these people trained within, I want to say, a week. We trained 30 people to do bedside.
Wow. Well, that's amazing. And probably I would assume that these are complex units. You talked earlier about they to take blood out of the body, they oxygenate it, they take the carbon dioxide out, they pump it back into the body, typically for a transplant patient that's getting an organ transplant and the lungs aren't able to do the work, or you don't want the lungs doing all of the work. So it's probably not something you write a job instruction breakdown, or you probably would have 40, 50, 60 of the regular job instruction breakdowns, wouldn't you, Kristen? Right. So tell me about, we always talk in job instruction, if the student hasn't learned, the instructor hasn't taught. Tell us about what it was like being trained to do one of those in that time period to be a bedside ECMO unit nurse.
So my staff members were able to come to the classes with Sarah, and from everything that I heard, Sarah is an excellent teacher, so they felt very prepared. She had, a pretty thick packet of education for them. They keep that with them. They took notes on it. We have had a few of our nurses that have done the bedside, in the bedside nurse for the ECMO patients, and as far as I know, everyone has felt very comfortable with doing that and being a part of that. But luckily, also with the ECMO, like Sarah said, you have the pump nurse that's there also. So they are able to answer any questions that any of my staff members had, just because they were so new at it. But they definitely felt well prepared, and they really appreciated her taking her time out of her day to get us prepared so that if we did have the worst outcomes, we were ready to do that.
And
Okay.
Sarah is not only such an awesome teacher, but I really appreciate her including point of care in that as well, because we were able to train those 30 nurses on the ISTAT to do blood gases as well. And that's very critical because they have to be able to make those changes, in ECMO and the ventilator based on those blood gas, values. So, I think all of this is just bringing in such great examples of scientific thinking and what obstacles do we have to overcome and how's the best way to do that. And I think that our CATA training has really helped us with that because, sometimes you really have to think fast on your feet and how do you get past these obstacles.
And talking about the ISTAT, tell us a little bit more about that process. Is that a blood draw? Is that is that a reading on the ECMO machine? Is that a complex process? What is involved with that?
So actually the ISTAT is a handheld analyzer that the bedside nurse would collect the specimen, whether it's from the ECMO or if it's before the pre or post oxygenator. We've done some creative things so that they can get different readings from different ports and sites. And so they would obtain the blood. There's a cartridge that they put the blood in, and then they insert it into the ISTAT. Within 2 minutes, they get blood gas results. So you can see that they can react very timely. And when you've got a real critical patient, you really need to be able to get those results very timely so you can act very quickly. So I was able to tag on to Sarah's classes and do the ISTAT training for those 30 CVICU nurses. So it was just a great team effort to be prepared.
Awesome. So now, Sarah and Jennifer, the patients that needed to go into ECMO, this isn't just a casual decision. There's probably a lot of factors go into this before the patient probably has to meet certain criteria to say, okay, we need to use the ECMO in this particular case if this patient's going to make it. So tell our audience a little bit about some of the things leading up to that, some of the symptoms that the disease was showing you or was giving you that you had to make that decision, and how that decision came about.
So when we talk about putting somebody on ECMO, you'll hear us use phrases like, oh, they're on our radar, oh, we're watching them. There's sort of this time where we're made aware of the patient and we just watch them, meaning we watch their ventilator setting. Our medical director, Dr. John Craig, will speak to the pulmonologist that's involved in the care of the patient, and they have conversations about optimizing the ventilator and maybe proning the patient, which means turning them on their stomach to help with oxygenation, and certain medications that sort of help with compliance with the ventilator, things like that. But as we kind of watch them, we make a decision, and the physicians make a decision whether or not they're a candidate for ECMO. And sometimes someone can be a candidate for ECMO, and then turning them on their belly for 24 hours while they're on the ventilator gets them over that hump and they don't need ECMO. And then other times someone can need ECMO and not be a candidate. Maybe they're, ELSO, which is the Extracorporeal Life Support Organization, is an international consortium of ECMO providers. They have a list of rule-ins and rule-outs for ECMO, and that includes age ranges, and specifically for COVID, that is. So that includes age ranges and weight and comorbidities such as diabetes and hypertension, all these things that we're beginning to learn about COVID, that if you have certain comorbidities, it increases your mortality. And so you look at Johns Hopkins, you look at Harvard, they all have these rule-ins and rule-outs that they utilize. And so when we look at these ECMO patients, we have to look at that big picture. And sometimes it's not so black and white. It's very gray at times, and you make the best decision for the patient that our physicians can make. And there are times that, we make that decision quickly, and it's an easy decision to make. And there are times that everyone's sort of on the fence about it, and it's a harder decision to make. But for the most part, people that require ECMO, their mortality is at least 80, sometimes 90%, meaning their chance of death is very high with COVID. And so when we choose to put them on ECMO, it brings them down to about 50-50, which is pretty good odds when you were at 90%.
That's great.
Yes.
That's great. And so then you can adjust the ventilator then to control how much the lungs are having to operate then, I would assume, because the ECMO is taking some of that work from them. Is that true?
Correct. So when you're on the ventilator, when we think about someone with pneumonia or COVID pneumonia, and they're not oxygenating well, or they're not getting rid of their CO2 very well, that gas exchange isn't happening on a cellular level. We turn the ventilator up. We modify the settings. We turn it up. We make those sick cells work harder, and we make the healthy ones work even harder. And so we call that injurious vent settings, or vent settings that cause more injury. And sometimes they cause more injury than they do good. And so when we are able to put someone on ECMO, it doesn't fix their COVID, it doesn't fix their pneumonia or their flu, or for what reason we're putting them on. It allows us to offload the work of the lungs to an extracorporeal or out of the body machine, and then we can turn the ventilator way, way down so that it's gentle ventilation, so we're not hurting the lungs anymore, we're not causing any damage or creating scar tissue anymore. And then in some cases, we're actually able to take people completely off the ventilator, and they can participate in their care still while they're on ECMO.
Wow, that's awesome. That's awesome. Those are some of the things we don't hear in the public many times. We just hear about the ventilators and things you hear on the news and on TV. Now, Kristen, I also read some things that you had done, some of your CVICU nurses had done to try and increase patient care and increase the patient experience and try and make some things a little bit easier on the patients. Talk to us about that. I remember reading an article about IV bags and some other things that you guys came up with, some obstacles you overcame.
Sure. So it was brought to all of us in the ICU, managers, directors, and our CNO about ideas that other Baptist facilities had, because we had seen it, on social media or in the news, different things that were going on in the nation about putting our IV pumps outside of isolation rooms for the COVID patients. And the idea behind that is that if you have those IV bags outside the room, the IV pumps outside the room, you don't have to go into the room as often to change out an antibiotic or something that's a short-term drip that goes in. So to save with our PPE, because that was a big concern at the beginning of this, was are we all going to have enough PPE throughout the nation and throughout the world? We tried to come up with ideas on a way to conserve PPE here in the hospital. So there were a few obstacles that a lot of the ICUs had that we had to work through. We did some testing, some experimenting with empty rooms and, just normal saline bags and stuff like that. We had to figure out how much of an IV extension tubing we needed to use on the different drips for different patients. We had to kind of measure, how far outside of the room these pumps would need to be. We had to figure out which doors to use in the patient's room. So after a couple of days of kind of going through it and trying to figure out if we could even implement this, we did decide that we could do it in our unit. So any of our COVID patients that were very sick on the ventilator and on multiple IV drips, we would put IV pumps, a set of IV pumps outside of the room. They would be plugged inside of the room and then go through a door. And the IV tubing extensions would be placed on all of the IV drips and tubing, and we would be able to operate all of the pumps from outside of the room. So, for instance, the first night that we tried this, it saved my night nurse from going in the room just to adjust the pump 12 times. So
Wow.
that was 12 gowns that he was able to save. And the time that he was able to save was having to don all of that and then doff all of it. So it definitely was helpful. We've done it quite a few times in our unit. Not every COVID patient qualifies to, for us to use that. If the patient's kind of moving around a lot and walking around, we don't want to extend their IV tubing outside of the room, because if they move too quick or something like that, they could easily pull out their IV. So it's generally patients who are sedated and intubated and not really getting out of the bed. And then different physical restrictions of the unit kind of make the decision for us. So if, there's a room where the door is really, really far away from the patient, and that's not necessarily a patient that we would want to use it on. So we try to look at all of that before we make the decision on whether or not we can implement that part of our treatment.
So no cottage board, no 5 questions, no official coaching sessions, but the thinking there and the data gathering and the testing in the separate rooms, everything you would do in a normal PDSA, you went through all of that to get to a solution to overcome the obstacle. That's great. That's great. That's what we want. We want the board, and the starter kata is what starts you off in that pattern. And then once I finish drilling through you so many times at the board, then hopefully that fades away, and then it leaves behind the thinking pattern. And that's what we try and accomplish in the end. That's what we're wanting to do. You mentioned also with some things you found on the internet about being able to help the patients feel more comfortable about the nurses they were seeing coming in the room, or some of the caregivers.
So part of being a patient, and you're sick already, you don't have family members that can come and visit you when you've got this virus. So and then the nurses are coming in, we have our masks on, we have a shield over our face. We've got our gloves and our gowns, and all you can basically see are our eyeballs. So one of my nurses brought to me, and I had seen it as well, but she brought to me the idea of printing out all of our pictures and laminating them so that we could disinfect. We could put it on our gown, and then when we left the room, we'd be able to disinfect that picture. So instead of taking our badges in the room, because we didn't want to get them, with COVID on it and then have to clean it and all that, I printed out everyone's badge pictures, laminated them for them, and then they were able to have them. So anytime they had to gown up to go in a room, they would be able to place it on the outside of their gown or wherever they could, so that the patient could see who they were interacting with. Because as you can imagine, it's got to be scary when the only people that you see all day, you can't see anything about them except for this part of their face.
Yeah.
So that was just something that we kind of thought that would kind of help ease their fear a little bit.
Right. And so the various patients had to also have diagnostic procedures and things that they needed to have go on. I would assume they would need scans. They would, I think, we had mentioned, I'd asked the question about what about patients that actually needed some surgery, or they needed something while they were in there to help them not only get over COVID, but to be treated. Talk to us about some of the things that you guys had to come up with to transport patients to actually doing surgeries.
So our Chief Medical Officer, Dr. Bill Cloud, actually, had a great idea, and he said, if we've got a COVID positive or COVID pending patient that needs a surgery, where would we do that? Because our ORs downstairs are not capable of being negative pressurized.
Right, they're down below.
Right, so that again is an issue that we would have had. So we looked at different areas in the hospital, and the area they decided would be best, since we had already made so many of our rooms the negative pressure rooms. We have kind of a corner room that's a big room that has an area in front of it that we were able to use. So what they did was they blocked off an area in my unit. They blocked off an actual patient room and converted that into a negative pressure OR. So they've used it quite a bit over the last couple of months. They use it for different procedures like placing lines, or they have done some surgeries in that negative pressure OR. So it's definitely something that's been utilized quite a bit, and it's definitely something that was really creative that Dr. Cloud helped us come up with the rest of the administration.
Wow, that's pretty amazing. I wouldn't have thought about that that necessity until we had some conversations about all the things that you all were facing during this time period. And so hats off to you. And finally, one final question, I guess, or any, if you guys have any, ladies have any other stories, anything else that you can think of that showed, that followed the Baptist management system or showed respect for people. Skip Stewart is very avid about including respect for people, and not only just the patients, but as well as the coworkers and everyone throughout Baptist. And is there any other things come to mind?
Oh, I think a major example of, of respect and trust and just the safety and care of not only our employees but our patients is that we have like code transport, and then like when there's a code blue, they call isolation. And these wonderful nurses probably can speak to that better than I can, but I just think that's a great example of how we respect our employees, our patients, our visitors to keep them safe. Because, and I'll just let them explain that process.
There's like a code transport, you said, or a code for isolation. Okay.
So we implemented a code that we've called code transport. So anytime a pending or positive COVID patient needs to travel through the hospital, whether that leads to a procedure, they're being admitted from the ER, or we're moving them from the ICU to a step-down floor, or vice versa, overhead we call code transport, and that alerts everyone that a patient who's pending or positive will be moving through the hospital, and they announce, which floor they're moving from and which floor they're moving to. So you kind of can clear the hallways to make sure no one is in line in the hallways or will be could be exposed. Security helps us with that, so they are the big proponents of that to make sure that everyone is safe. They go to the elevator and secure an elevator so that if you've got to go get on the elevator with your patient, you're not waiting on an elevator and just standing there. They've got the elevator ready for you as soon as you get there. When you get off the elevator on whichever floor you're going to, our CVS or housekeeping department is there and available, and they start cleaning that elevator as soon as the patient gets off of that, and security continues to escort you to your destination or where you're going. And then they call the code transport all clear once the patient is there, so everyone knows that they can go about their business again in those different areas where the patient's coming from. So I really feel like that helps keep all of us protected. We know that there's a patient coming through, and it helps keep visitors protected, making sure the elevators are clean and we're not exposing anyone unnecessarily.
Wow, and that's something the public definitely would feel comfortable, more comfortable coming to Baptist, knowing that you guys are going to that length to protect the patients that you do have, the non-COVID patients, and so that's just a great extension of respect for people, I think, that holds true to your values and everything. Well, I want to thank all four of you ladies for joining us today and sharing your accomplishments and your experiences through this pandemic. I want you to know we're all praying for you. You're all our heroes and heroines these past few months and the years coming ahead. And we know that we've got a lot of fight in front of us, and your frontline workers are definitely key to that safety and health for our families and those that that we have coming into your care. So I want you to know that we're praying for your families, we're praying for you, and praying for all the support structure that's around you, and we want you to know that that our thoughts and prayers are there for y'all.
Thank you.
Great.
So much.
And we want to just say God bless, and you ladies have a great day.